Thank you very much for the invitation. It's a great honor for me to be invited to participate in this important event. Um, and the people of Zimbabwe are in my heart. I am trying to support the development of fetal medicine. I have given equipment for the establishment of a fetal medicine unit, and I'm in close contact with the ambassador of Zimbabwe in London, and in November, the First Lady will be visiting our unit in London. I will discuss briefly in the next 30 minutes different aspects of fetal medicine. First of all, the diagnosis of fetal defects. We have moved from a period where we could not diagnose fetal abnormalities into a standard of care, which included a routine ultrasound scanning pregnancy. And now there is a lot of emphasis given to the first trimester of pregnancy. Women are having a routine ultrasound scan at 12 weeks for the measurement of nuchal translucency, primarily as a method of screening for Down syndrome. But in reality, during this scan, it has seen an evolution into becoming a mini anomaly scan. And you can classify fetal abnormalities according to what we see at this scan as always detectable, like acrania and holoprosencephaly, body stalk anomaly, severe cardiac defects, exomphalos and gastroschisis. Those that are mostly seen if we specifically look for them, like spina bifida, hypoplastic left heart, various amputations of the limbs, and severe obstructive uropathy. And at the other end of the spectrum are abnormalities that cannot be seen in the first trimester because they only become apparent in the second and even third trimesters of pregnancy. So yes, we need a mini anomaly scan for everybody at 12 weeks, but we need to continue to do scans at 20 weeks. And I also believe that all women should have a routine ultrasound scan at 36 weeks in pregnancy, because there are certain abnormalities that become apparent only in a late stage of pregnancy, like severe microcephaly, for example. The second aspect that I want to address is that of screening for chromosomal abnormalities, and I summarize in this slide the evolution of screening over the last decades. In the 70s, the method of screening was maternal age. If women were over the age of 35, they had an amniocentesis. But the vast majority of chromosomal abnormalities were happening in younger women, and therefore the overall detection rate was only about 30%. In the 80s, we had second trimester serum biochemistry, where the scan, where we combined measurements of alpha-fetoprotein, free beta HCG, estriol, and inhibin A, and the detection rate improved to about 70%. And in the 90s, we had the era of the first trimester nuchal translucency together with free beta HCG and PAB, with a detection of 90%. More recently, of course, we had the introduction of cell-free DNA testing of maternal blood with detection rates of more than 99% and a very, very low false positive rate. The test remains expensive in many parts of the world, and therefore, when it is being introduced in several countries, like in England and Western European countries, we have a primary method of screening based on the first trimester combined test, nuchal, free beta, and PAB. And if you have a risk above a certain cutoff, then you are offered a cell-free DNA test. What about pregnancy complications now? The main cause of death and handicap in obstetrics is preterm birth, prediction and prevention of that. The incidence of preterm birth before 37 weeks in our poor inner city population in London is about 6%. But the focus really is not on delivery before 37 weeks, it is delivery before 34, 32 weeks. And the incidence of that is only about 1 to 2%. Half of them are iatrogenic, mainly for preeclampsia and fetal growth restriction, and the other half are spontaneous preterm births. Now, in the prediction and prevention of spontaneous preterm birth, a critical importance is placed by the measurement of cervical length at a routine 20-week scan. And if the cervix is less than 25 millimeters, several studies have been carried out to find out what can we do to reduce the rate of preterm birth. Cervical cerclage can be useful, and it reduces the rate by about 30%. Vaginal progesterone can also reduce the rate by about 30 to 40%. And people have also tried to use this Arabin silicone pessary around the cervix with controversial results. Some studies show it is very good. In our studies, it was not useful. So the primary method of prevention is to screen everybody at 20 weeks. If the cervix is short, give them progesterone, scan them again after 1 or 2 weeks. And if the cervix is stable, great. If the cervix continues to shorten, then consider inserting a stitch. In twin pregnancies, the rate, of course, of preterm birth is much higher than in singleton pregnancies. In singleton pregnancies, as I said, the rate is about 1 to 2%, whereas in twins is 10 times higher, about 15%, and in monochorionic twins is even much higher at around 28%. So although twins contribute about 1 to 2% of all pregnancies, they contribute about 20% of the total rate of preterm birth. Unfortunately, in twin pregnancies, nothing very much appears to work. Bed rest, progesterone, cervical cerclage have not been shown to be beneficial. However, in a big study that we carried out in twin pregnancies, we found that progesterone given to women 600 milligrams every day from 12 to 34 weeks, there was no reduction in the rate of preterm birth, but in a small subgroup of women that had a very short cervix from the first trimester, it appears that progesterone in those women may be beneficial. What about preeclampsia? Preeclampsia is important. It is responsible for many deaths in the world. I'm sure that many women in Zimbabwe die every year as a result of preeclampsia. More than 45,000 women die every year in the world, and more than 500,000 babies and fetuses die as a result of preeclampsia. For those of you that are interested to learn more, there's a very good review article that we wrote at the end of last year in the New England Journal of Medicine, which covers prediction, prevention, management of preeclampsia. Now, the traditional approach to identifying the high-risk group is to ask women a few questions at the beginning of the pregnancy. This is true in England, in America, and I'm sure the same is true in Zimbabwe. Now, the questions are whether you had a previous preeclampsia, whether you have renal disease, hypertension, diabetes, autoimmune disease. If the answer to those questions is no, then we ask the women again if they are in their first pregnancy, if they are over the age of 40, if they have a high body mass index, and there's a long interval between this and the previous pregnancy, and whether they have a family history of preeclampsia. It's a very simple way of identifying the high-risk group, but unfortunately, it has a very poor prediction of preeclampsia. We classify about 10% of women as being at high risk, and this group contains only about 40% of the total. So as a method of screening, is quite poor. A new approach that we have developed over the decades is to combine information from maternal history together with uterine artery Doppler, mean arterial pressure, and placental growth factor at 12 weeks. And in a head-on comparison in England, involving many thousands of women, we use the risk scoring system, the pink histograms, and the triple test from the Fetal Medicine Foundation, and the detection rate of early, preterm, and term preeclampsia with the Fetal Medicine Foundation triple test was twice as high as that of the risk scoring system. Now, the triple test is the ideal mean arterial pressure, uterine artery Doppler, and PLGF. However, you may say we don't have enough money to spend on PLGF, in which case, fine, you can use a combination of mean arterial pressure and uterine artery Doppler, and you detect 83 rather than 90% of early preeclampsias. Or You can say we can measure PLGF, but we don't know how to do Doppler. Again, you can get a detection rate of nearly 80% rather than 90. It's a lot better than what we do now. And I think that that should be instituted. Now, a new method of identifying the high-risk group is to look at the ophthalmic artery. And this is much easier than doing the uterine artery Doppler. We just put a transducer with a bit of gel over the eye of a woman, and then it's very easy, really, because you see a big black circle that, of course, is the orbit. You put the color Doppler on, and there's only one blood vessel, so you cannot get confused. And then you get a special waveform where you have a first systolic wave, a second systolic wave, and then diastole. The first systolic wave is produced by the contractility of the heart and blood going into the head. The ophthalmic artery is the first branch of the internal carotid artery. Blood then is going into the periphery. It hits small arterioles and is reflected back into the heart and again into the brain to give you a second wave. So the second wave is a reflection of peripheral resistance. And in this first trimester study, for example, we found that a combination of first trimester ophthalmic artery Doppler together with MAP, blood pressure, and PLGF has a detection rate which is very, very similar with that of using uterine artery Doppler. So you can replace uterine artery Doppler with a much simpler measure of peripheral resistance, which is just the ophthalmic artery, which takes a few seconds to do. What about prevention of preeclampsia? Well, all sorts of things have been tried, bed rest and supplementation of the diet with various medications, magnesium, zinc, and so on, but nothing works. There is controversial evidence that calcium may be beneficial. The evidence is controversial because, as I can show you here, in the very big studies involving many, many thousands of women, there was no benefit at all. And then you have a very large number of very small studies with a very high risk of bias, and somehow these small studies are shifting the way the meta-analysis are carried out, the conclusion that calcium is beneficial. I think there is very poor evidence that calcium is beneficial. Look at this graph on the right. One study, and that is the study by Levine, the study by Villa, that accounts for 50% of all the data, shows no benefit. Then we take the three biggest studies, Villa, Levine, and Belizar. The three studies together account for 84% of the total, no benefit. And then you have a series of silly small studies that are now pulling the way the meta-analysis are carried out. They're pulling the effect down, and they present this, I think, false hope that calcium is beneficial. I don't believe there is good evidence that it is. The only thing that is definitely beneficial is aspirin. In this study involving nearly 27,000 women, we screened the women by a combination of maternal factors, mean arterial pressure, uterine artery Doppler, and PLGF. We identified the high-risk group, and then we randomized this into aspirin, 150 milligrams every day from 12 to 36 weeks against placebo. And we found that the treatment reduced the rate of preeclampsia by 90%, of early preeclampsia, preterm preeclampsia by 60%, with no effect on term preeclampsia. Now, preterm preeclampsia is responsible for a lot more mortality and morbidity than term preeclampsia, but because there is a lot more term than preterm preeclampsia, the overall contribution to adverse outcome from term preeclampsia is more. So term preeclampsia cannot and should not be ignored. In the study that we are carrying out now, we are screening for preeclampsia at 36 weeks, and based on the individual patient risk, we are timing the time of birth so that if they have a very, very high risk, we deliver them early, and if they have a low risk, we deliver them later. And we anticipate this study to finish in the next 3 months, and we expect that it will reduce the rate of preeclampsia by more than 60%. What about intrauterine therapeutic interventions? Then we have a series of important interventions like blood transfusions for fetal anemia, and various shunts for hydrops, fetoscopic laser surgery for twin transfusion syndrome and fetal growth restriction, insertion of a balloon for diaphragmatic hernia, and fetoscopic surgery for open spina bifida. This is the evolution in the management of Riesler's disease, where you put a needle into the umbilical cord or the heart, and you give a transfusion, and now babies that would previously die, in more than 90% of the cases, they survive and they do well. We have the insertion of shunts in babies with pleural effusions, and again, with very good results in terms of survival. And this is from a picture from the 90s when we introduced endoscopic laser surgery. Today, we have the retirement party of Kurt Hecker. This is Kurt Hecker in Germany, Yves, and that's myself in 1992 when we started doing endoscopic laser surgery for severe twin-to-twin transfusion syndrome. And with this approach now, many thousands of babies in the world have survived that would have previously died. So, and the next method of fetal surgical intervention is that of endoscopic insertion of a balloon in cases of babies with diaphragmatic hernia. We introduce an endoscope at around 26 weeks in pregnancy in cases of severe diaphragmatic hernia into the uterus. And then we go through the baby's mouth into the trachea. This is going over the tongue. The bottom is the tongue, and then this is the uvula. We enter the oropharynx. That is the epiglottis. You go under the epiglottis into over the vocal cords and introduce a balloon at around 26 weeks to block the trachea. In fetal life, the lungs produce fluid which escapes into the amniotic cavity. This fluid is then obstructed from escaping. The lungs expand, grow, and improve the survival rate by 3 times in the severe cases of diaphragmatic hernia. A final topic that is receiving a lot of attention now is that of surgery for open spina bifida. There's some evidence that in fetal surgery for this condition, you can reduce the rate of needing postnatal shunts, and perhaps you are improving mobility of the lower limbs and urinary function. You can do this by doing open fetal surgery, cutting, doing a myomectomy, and then repairing the defect, or better, by endoscopic surgery, where you do everything by removing the amniotic fluid, replacing it with carbon dioxide, and doing endoscopic repair of the condition. So I have given you an overview of different aspects of prenatal diagnosis and interventions, and thank you very much for the invitation.